Thank you. Good morning, everyone. My name's Jen McCabe, and I'm far from perfect. I have bare feet today in honor of Matthew Sanford. So Matthew, the dogs are out to play. Hopefully everyone else will be too. I want to start bridging the gap between Health 2.0 and the wider involvement of people in social networks. My fascination is how to translate important bits of data that we share about ourselves into science, and capturing the value of micro-choices that are shared in online communities and social networks. I have 10 minutes and a lot of cards, so bear with me if I speed up here. So what does this mean, basically, for healthcare? There is still a lot of uncaptured data outside of the biometric sets that Indu shared with you. People are telling stories online. Those stories can be broken down into small bits that are interesting, at least to me, and small bits may be clinically relevant. We don't know yet, but that's what I hope to find out. So I'll start with a story. At 2:30 on September 4th, 2000, Labor Day weekend, a 20-year-old college sophomore left a friend's house and began the 35-mile drive home. At approximately 3 a.m., our patient fell asleep at the wheel, drifted across 2 lanes of traffic on a rural Maryland road, and struck at an elegant, restrained speed of 45 miles an hour, an 8-foot iron ship's anchor, for lack of a better descriptive term, dead on. As the car crushed around our patient and pinned her to the seat, her right knee and ankle basically imploded, sending her on a journey, 10 years, 15 surgeries, various provider interactions, all kinds of interesting medications and treatments. Ironically, this story and what has happened since is the best thing that's ever happened to me. My name is Jen McCabe. I'm here because I'm a person who's a patient. I'm here after 9 years to ask you some questions about how we can transform healthcare together. My goal is to make not just the accident, the trauma story, the diagnosis, which is so viscerally powerful that it leaves me shaking, but how the everyday experiences and the micro choices that matter for me in my longer-term health goals can become clinically relevant. My research as a CASOT fellow at the Health Strategy Innovation Cell at the University of Toronto, who was brave enough to take me on despite my non-academic background, is in building systems, software and social media applications mainly, that program choice into patient and provider interactions. As a recovering English major, it's pretty much the only thing I could find, and it's a good way to catalyze the community and communication using technology. I am an e-patient, I am a blogger, I am a health tweet. I don't have a master's degree, I'm not seeking a PhD, and I'm not a doctor. But I am obsessed with the challenge of enabling the sharing of patient stories in a clinically meaningful way. I'm obsessed with education via co-experience and the idea that illness narratives have something to teach all of us. In the next 7 or so minutes, I'd like to walk us through where patients are talking about these experiences online, the value of choice and micro-choice, and finish with a question again in how you'd like to transform healthcare. For a lucky majority of us, health is our homeostatic default, and sick is what happens in the interim when our normal state is disrupted. This means that most of the data that's relevant for my overall life goals is not captured currently by the healthcare system. But I do share it in online social networks. When we're sick, trying desperately to return to this nuclear nirvana that's health, we have decisions to make. As Victor Montori illustrated so elegantly yesterday, we have no idea about the range of solution sets that are available to us as patients. Now, why should you care about illuminating the language that patients use to describe health and potential solutions to being sick? The semantics of healthcare as a conversation that we use naturally, the lexicon of learning what it means to be a patient, these are described in very self-centered terms. They're very patient-centric. That's shocking, right? We describe what we know, and that's ourselves. Broadly speaking, there are 3 general categories that matter when we assign meaning to healthcare experiences in social networks. I talk about me, right? I talk about you, and then I talk about everything else. So I-UX, me, you, everything else. That everything else, category X, is what medicine deals with. but it's the me and the you dialogue that's missing in the delivery of care. This means that my fears go unexplored, my past history may go unplumbed. Where in today's system do I go to learn about the range of choices available to me? Unfortunately, the answer is more often than not nowhere. Conversation about options is something our doctors do to us in their spare time. Even in shared decision-making models, we often fail to talk about a range of choices available as a potential solution set to be explored in a context that is both personally relevant and clinically coherent. I don't pretend to know what that second one means. Since I'm not getting this kind of back and forth conversation from my doctors, and I represent the kind of patient who wants to be involved and engaged, and not all do, I'm going elsewhere to find it. I'm going where other patients and caregivers, even providers, are talking about their experiences, sharing hard-won knowledge that may be of use to me. Okay, so I'm going to the cloud, and I'm trying to bridge what I'm learning online with what I'm finding in my real-world care delivery. That means that I integrate what I learned from other patients and what I learned from my provider. And of course, I want to be right in the middle of all that. Now, interestingly enough, I can find information about my care and about potential solutions, both online and offline, right? In my prognosis, in my SOAP notes, in my conversations with my physicians. But where's my community? That's most definitely online. I don't chat with my doctors on Twitter, but I do chat with other doctors on Twitter. But then what's missing is the opportunity for me to engage in a commercial transaction with either providers who make those interactions easier for me, or with services like 23andMe, or Patients Like Me, or Cure Together, which you'll hear about later today, that allow me to devote that information to research. That's a non-monetized transaction of my healthcare data. What's still missing? The personal context that lets me put that into my larger life goals and picture. I'm going where other patients, caregivers, and providers, again, are sharing that knowledge. I'm going to places where exploring my past history, the good, the bad, and the ugly, is able to be shared in a way that's potentially useful for others. I'm going to those sites and services. In fact, I wouldn't be here today if it weren't for countless hours spent in participant observation on Twitter. So thank you to everyone on Twitter for helping me get here. Hear my story, whatever it means, whatever being a patient means to me, is part of who I am, not the sum and total of my identity. Here, dignity can be reclaimed, identity reconstructed in a way that helps me heal, however I take that to be, through a profile page, through an avatar, through a picture, through a pen name. Now I'd like to ask you some questions. I'd like to posit some potential value for the sharing of these experiences to the current healthcare delivery system. If you choose, and I hope that you will, to begin exploring and monitoring these kinds of communities, just dipping a toe in the water, in addition to the chatter about diet, about exercise, about sex, drugs, and rock and roll, about dealing with life post-diagnosis, you may find something disturbing, at least initially. You may find a disheartening buzz of frustration, of anger. People have had it with a lack of access to help and support. And when they reach this point of frustration, others commiserate, reach out, write on my wall, shoot me a direct message. What first scared me about social networks as a researcher, amateur scientist, is that some people feel injured, insulted, even assaulted, as Matthew mentioned yesterday, by healthcare. That's the bad and the ugly. But where's the good? Some patients, when they can't find value elsewhere, are educating each other online. But there's still quite a gap to be bridged there. We're bringing our subjective personal knowledge about what works to bear, but we need you. This doesn't exist in isolation. Why would patients trust the information that they find from other patients who are not credentialed, who are unproven, who don't have degrees, who haven't done residencies, even potentially unprincipled people who give false information? There are several reasons. One, unfortunately, it's all we've got. Two, it's what I need when I need it. It's real time. Three, it's accessible. It's savable. It's shareable. I have control over how I spread that information. It's opt-in. Four, it's free or very low cost to obtain. In other words, it's not great, but it's just good enough, and you aren't providing me with other options. In medical care, providers determine what information is valuable for me to know based on a snap judgment about my capabilities and limitations. The right choice, the right solution set for me is assumed and then served. The info set is based on a population-relevant diagnosis and a statistical prognosis, and I am neither. In online communities, I can set my own value scale. I proactively seek out information relevant to my fears and goals via the channel of my choice, mobile health, my iPhone, the web. Conversation in online communities seems to holistically evolve, and the research in this is very early, into the sharing of stories first, providing decision support via the Health 2.0 community second, and then establishing a trusted network of mentors and peers, as I've had the privilege to do on Twitter. Here, the burdens of care, the burdens of choices, can be shared via the distributed network, and the minutia of daily micro-decisions finally adds up to something valuable. What I think we may find over the next year of research and development is that micro-choices matter on a macro scale. One of the questions I'd like to explore is health, or the lack thereof, at least partially the result of cumulative set of everyday decisions that add up to a recipe for my health. We're just beginning to define and quantify and measure these micro-choice data sets. It is very, very young study. It feels a bit like the days of antibiotics, at least from what I've read in my 8th grade science text. A gross fuzz, a mistake in a petri dish, no one thought was relevant, revolutionized the treatment of bacterial illness. Are social networks the new penicillin? I have no idea, but it's an interesting question. So why might the study of micro-choices matter to all of you? We're talking transformation here, right? Or at least I hope we are. To transform, you need incentives, you need value models. I'd like to propose one example, just one, of potential value being generated as patients share everyday choices. Yesterday, Dr. Cortez said the greatest opportunity for value capture is at the translation interfaces. We heard that process optimization may be the answer, but I think, or at least I hope, that it's people optimization that provides the greatest opportunity for transformation. Why? Again, countless hours spent doing participant observation in social networks like Twitter suggests that patient narratives are translation available interfaces. I say available because we're failing miserably to capture and redistribute the potential value generated in these communities on a volunteer basis every day. We are being left behind, maybe rightly so, as highly activated patients surface new questions and new answers. Speaking of questions and answers, patient micro-choices are being detailed in online communities, and what questions they're asking have certainly helped me reframe my own research. As Dr. Cortez said yesterday, we don't have the cookbook, but maybe we don't need it. Perhaps patients are already rewriting the recipes for recovery. Another benefit of using social networking data, people are doing things fast. They're exploring quickly, and they're sharing and responding, usually within 24 hours. I don't know about you, but I don't have 17 years to wait for a new technique to get from the bench to my bedside. My community, my personal experience, and that of my distributed network may help narrow the distance from study to the bench. How? The power of numbers. A self-motivated, active, engaged network that already exists. You don't have to build it. You just have to plug in. I'll ask you, please, for the sake of the system, read Patient Recipes for Success with a more questing mind. Listen openly to what you're going to hear Alexandra share about the Cure Together community later. Even if you don't believe after hearing this that Alexandra's community represents real, actionable clinical research, it can certainly drive new research opportunities. When I hear terms like evidence-based medicine and checklists, at first I'm encouraged, and then I wonder what it will mean for the questioning that occurs between patients and providers. Evidence-based medicine is about endpoints. Yeses and nos, knowledge domain, care delivery, capture and creation of value. It's a final answer. Where does evidence-based medicine come from? Closed-ended systematic questions. Who is well? What does this mean? Is this effective? Yes, no. The difference in this data is that it leads us to a cornucopia of new questions. Health 2.0 for the existing community is more about questions being the product than answers. We have a great deal of understanding to do about why some patients view the healthcare experience in this way. The old model, "This is your experience," statement. The new model, "What is your experience?" question. This is the product of participatory medicine, and it's the product of discussing choices and control. Patients are forging partnerships. Patients are defining participatory medicine for ourselves. I was listening to Clayton Christensen talk about Michael Dell building a computer in his basement, in his dorm room, and thinking, what's the healthcare equivalent of that construction? And I would suggest that it's e-patient networks coming up with solutions on their own time. Don't worry, though. The purpose for many of us sharing these narratives is not to disprove your life's work or bring about a state of e-patient-oriented anarchy. Do I look like an anarchist to you? Don't answer that. The purpose is to help us navigate the system. The purpose is to help ourselves and our loved ones survive traversing it, whether it's through cathartic sharing via stories, whether it's through co-navigation, sharing biometric data sets, whether it's through link sharing, support, etc. You don't have to be credentialed to have a conversation about healthcare observations on social networks. As Elizabeth said yesterday, everyone has a story. Everyone has a narrative dotted with personal collisions with the healthcare system. And now to the choice that I'd like you to think about before I show you one final example. It actually is black and white. And I think that if you make this one choice about healthcare transformation, if you can answer this one question, all the resources we need after to transform healthcare are available to us, or they'll be made available through the generosity of patient and provider communities. We have two choices. The first one is black. We can choose to discredit these communities, and healthcare transformation will happen without us. The mutants will gain market share and become the next circle of disruptive innovation. Or then there's the white choice. We can choose to engage these communities in discourse and transform healthcare in a collaborative fashion. As I leave you with this choice, and obviously you know which one I'm rooting for, at least I hope you do, I'd like to leave you with the words of a doctor who obviously understood a significant deal more about capturing value in the healthcare system, William Mayo. Thank you very much.